Pleasure. Welcome, everybody. As Anne said, tonight we've got Dr. Carlo Rinaudo. He's a registered chiropractor, researcher and educator. He's over 21 years of private practice and obtained clinical postgraduate training in functional neuro-rehabilitation and sports chiropractic. Dr. Rinaudo is the clinic director and founder of a multidiscipline clinic based in Sydney, focused on helping people with a range of complex neurological conditions. I myself have personally been to see Dr. Carlo, and he helped me greatly. He has completed a Ph.D. in vestibular therapy at University of New South Wales and neuroscience research, Australia, where he continues to be active in vestibular research, pushing the boundaries on our understanding between the brain, vestibular system, and the human body. As I said, I've personally been treated by Dr. Carlo, and he helped me get my confidence back on track to have health goals and aim to where I'd like to head to keep me strong. And I still do many of his exercises. So thank you for helping me, Dr. Carlo. Please welcome Dr. Carlo.
Okay, thank you. Look, I jumped at the opportunity when Anne asked if I wanted to present to your group, and I did so open heart. And I think tonight I'm looking forward to sharing some of my thoughts on Meniere's, and I'm going to talk about some of the new technology and advances that research and clinical applications are starting to produce with good results. And I'll obviously talk about my experience in practice as well. So so obviously big thanks to Anne and the team. And I was pleased to see Anita and others take part in tonight. So again, I appreciate the opportunity to be here talking to you guys. Just a disclaimer, and I guess this is important because I want to be able to my apologies. I want to be able to set the intention of what this talk is about and what it's not about. So obviously the material that I want to talk about is really information that I've gathered either through personal practice, research, or through education. It's not to be considered or intended as providing personalized medical advice. Please always seek your own doctor, whether it be medical, allied, or specialist, in more advice that's specific for you. And it's up to the discretion and the judgment of the sole responsibility of the recipient of the information to determine if any of the products, assessment, and therapies prescribed are appropriate. So my talk is really going to be quite broad. I'm going to outline some of the things that works for some, and in some instances for many, but it may not be appropriate for yourself. So the information provided should not be considered as a claim regarding any procedure or treatment. And so certainly some of the tests and the procedures have yet to, I guess, pass through the rigors of validated science in terms of randomized controlled trials, or pass through the rigors of what most people would consider to be best practice. So some of these things that I'm going to talk about are on the fringe, some of them are off-label, and some of them are best practice. And I'll try to identify where those are so you can be best informed. But really the intention of this talk, more than anything else, is I want you guys to think about, if anything, have more questions, raise more questions as to potentially what's causing your conditions. I'm not here to answer everything that relates to Meniere's or in particular your condition, but really I want you to think about an integrative or an holistic approach to treating Meniere's disease. And so with that, if you could walk away with a set of questions that you can either ask yourself or your primary health practitioner, I'd be pretty happy with that. I think health comes from you being inquisitive and wanting to know, learning about yourself. And hopefully by the end of this evening's presentation, I've dropped a few things that make you think about where you could be spending your energies and resources to help you lead, I guess, a healthier and better quality of life. So that for those who don't know, I'm sure the inner ear is something that many of you who have experienced Meniere's have looked at and wondered, where does everything fit? So very broadly, hopefully this is not a this doesn't come as a surprise to you, but we're looking at the ear. We're looking at the external ear, which is obviously where we have the earlobe and the ear canal. We have the middle ear, which is made up of the tympanic membrane or the eardrum, and the little ossicles or the bones that help transduce sound into, or airwaves into sound. And then we have the inner ear, and the inner ear is where I think most of us want to spend our energies. And it's really, it's broken up into two parts, one of which is the vestibular apparatus. And the vestibular apparatus is made up of these three semicircular canals. And then we have the cochlea, and the cochlea is where we is used for hearing. And it's generally, in Meniere's, we have both these areas are affected. So both the vestibular portion, which relates to our ability to detect motion and our sense of dizziness and balance, and our cochlea, which is involved with a sense of sound. Okay, well, the rest was just intro. And anyway, you're all getting a copy of these slides, so don't worry too much. You certainly don't have to scribble down any notes. You're getting an video recording of this, and also my notes as well. So yes, so there's the orientation of the ear, but most of you would be familiar with it. So again, with Meniere's, most of us would understand that it's described as a spontaneous, episodic type of condition that involves a combination of vertigo or spinning sensation, medium to high frequency hearing loss, tinnitus or ringing sounds, and a sense of fullness or discomfort in the ear. These episodes can last anywhere between 20 minutes to sometimes several days, but typically 20 minutes up to several hours. And it is described as a peripheral vestibular condition. The importance of that, I'm going to draw upon you very shortly, but it's important you understand that it's really a condition of the inner ear, or at least classically, it's described as such. I'm going to shake that up a little bit with some of the things that I'm going to be talking about tonight. The treatment options would be, there are conservative ones, and there are vestibular suppressants when one has an attack. Stemetil benzodiazepines are the most commonly prescribed. Most people are familiar with a low sodium diet and diuretics to help minimize these episodes. And to help abate symptoms, or to help minimize the severity of the dizziness and the balance issues, most people have been exposed to some form of vestibular rehabilitation and lifestyle modification. Unfortunately, for those that have intractable Meniere's, where the condition, and particularly the tinnitus aspect, has persevered for a period of time or at a severe level, corticosteroids, gentamicin injection into the middle ear are likely to be prescribed. And for those right at the end, we're looking at nerve sections or labyrintectomies as sort of the last stage ways to manage some of the symptoms. So going back to what I was mentioning before about the peripheral aspect. So just by definition, when we talk about peripheral vestibular system, we're really referring to that inner ear that we mentioned, the organ of the inner ear, as well as the nerve that connects the inner ear to the brain. So that's referred to as a peripheral vestibular part of the system. Central vestibular systems is not one that's normally associated with Meniere's, but it is important, and it really is the information that is taken from the peripheral system, and it's interpreted, it's defined, it passes through many filters to give us an understanding of our awareness. It gives us our emotional response. It gives us our cognitive response. It gives us our whole body response. So when we talk about central vestibular pathways, we're really talking about everything else apart from the inner ear. So we're talking about the brain, or this primitive part called the brainstem. We're talking about higher areas of the brain. All these are often neglected when it comes to managing someone with a a purely peripheral vestibular condition, of which Meniere's disease is one of them. So any of you who've been to vestibular therapy or had any sort of therapy apart from pharmaceutical intervention will have had therapy that's often specific to helping the inner ear work better, and maybe with some minor aspects that relate to balance and some stability. But often we neglect areas that relate to our autonomic system, to our spinal system, to our eye movement system, to our fine control systems, to our cognitive systems, to our memory systems, to our body awareness systems. These are areas that I strongly believe that if we can enhance with people with Meniere's, then I'm confident that, and we've seen it in our office, that we can improve their quality of life and improve resilience and adaptability. And they're two words that you'll hear me say a few times: improving resilience to reoccurrence and adaptability, so you have more capacity to endure and enjoy life despite being rattled at times with some of these flare-ups that you might have. I'm just trying to, how did I navigate through this? Oh, next slide. I'm just trying to work, oh, we go, okay. So the role of these central networks, if you think of it like a big amplifier, and on an amplifier, you have all these knobs and these buttons, and that can adjust the volume and the pitch and the frequency and all these little nuances that relate to that sensory information that comes in. So what the brain does essentially, particularly as it relates to vestibular function, is it can adjust things. It can increase the amplitude, it can decrease the volume, it can increase the pitch, it can increase how our brain and body responds given an altered signal that comes from our inner ear. Think of it like a, you've got an AM radio and you want to digitize it. You want to make it like an FM quality, or if you want to make it a digital quality. You really need a lot of amplifiers and synthesizers that can take that information, that analog FM signal, AM signal, sorry, and you can play with it so the signal becomes clearer and your body can make, and you can make more sense of what's coming through. Think of those central networks as being exactly that. All these little volume knobs that are scattered throughout our brain can take that otherwise compromised auditory and vestibular input, including tinnitus, can change that input and make it more palatable, tolerable, and livable. And if we can work on getting those central networks to be healthier, more adaptable, and as I said, more resilient, you're going to have a far greater chance in not having those symptoms take such a burden as I know they do with many patients. So the healthier that central system is, the more resilient and adaptable the body is. And that's going to be the mantra through this talk, because my talk is not going to be things that you've heard about typically with Meniere's, but rather what can we do as a whole body to get the brain and body to be more flexible, more adaptable, so you can generally live a more fulfilling life. I'll try to keep some of the technical aspects of my presentation down. This is probably one of the more technical slides, but I'll break it down hopefully quite nice. So here's the inner ear, and we've got our cochlea, and we've got our vestibular portion. So we've got our hearing, tinnitus aspects, we've got our vertigo-based aspects that relates to the inner ear. The information from this area feeds through a nerve and reaches our brain. And these areas that coordinate, and remember, think of that big mixer board with all the volume knobs, sits in many parts of the brain. We've got information that comes from our neck and our body, otherwise known as proprioception. So proprioception is a big word. All it means is information that is gathered from our body and gives our brain an understanding of where it is in space. We have information from different parts of our brain, including our cerebellum, which is really involved with fine motor control, oculomotor inputs, which is information that comes from our eyes, our cortical inputs, which is information that comes from higher brain centers. And these come in together in conjunction with our inner ear and gives us these three main outputs. It gives us an output that relates to balance and posture. It gives us an output that relates to our eyes and keeping our eyes stable, and gives us an output that relates to giving us an understanding of where we are relative to space. Now, almost all, if not every Meniere's patient that I've seen, we see a compromise in balance and posture and stability. We see a compromise in vision stability, and we see a compromise in our understanding of where we are relative to space. Now, sometimes this is only prevalent when we're having
Hi, Carl, just letting you know your internet's frozen.
hello, can you hear me?
Yes, you're back now. Thank you.
Okay, my apologies. Was it just me who dropped out, or did the whole
Yeah, no,
drop?
it was you. You froze and then you dropped out. So
my
it's all right.
apologies. Sorry about that.
That's okay.
So let's carry on there. So excuse me. The role of any sort of therapy, in my opinion, should be, particularly as it relates to Meniere's, should be about a couple of main things. One, improving quality of life and managing symptoms. When it comes to an episode of or an attack of Meniere's, most people would feel pretty comfortable in staying at home and not venturing too far. So often there's not much that say someone like myself could do, but certainly your first line round of medication could certainly assist. But in between sessions, we really want to focus on improving your stability, improve your mobility, reduce anxiety and fear, and try to encourage you through support and through exercise, your return back to normal activities. So our focus is really aimed at trying to reduce the frequency of some of these episodes, but when they do, maybe have a few little what we call neuro hacks or other means in which we can reduce the severity, but often it's a case of medication. But in between these episodes, give you the confidence and give you the tools to be able to get you back to participating in normal activity as quick as possible. So what can influence these central pathways that I mentioned? What is it that we can do to improve your ability to have more adaptation and be more resilient? And this is not an exhaustive list, but a list that I go through with my patients at one stage or another, and it's listed here. So we often talk about metabolic, which is a broad term that looks at dietary and how your systems of your body work, from including blood sugar level to thyroid to anemias to autoimmune conditions to many things that relate to the systems within. We look at medication, and whilst I'm not in a position to necessarily recommend, advise, or prescribe medication, but even the combination of different medication, or what we call polypharmacy is one that needs to be often discussed with patients. Autonomic function, the area of the brain that relates to autonomic control of your body parts like breathing, blood pressure, heart rate, gut function, stress response, are very important things. And we're going to go through each of these in more detail in subsequent slides. The sensory interaction between proprioception, vision, and vestibular function, and how the brain processes this information are all topics that really should be discussed with your primary practitioner in trying to get those central pathways or central systems functioning higher or functioning better. Wherever possible, I try to include some research just to, I guess, substantiate what I'm saying. So you're not looking at this as going, oh, Carlo's made this up. He's only cherry picking information that relates to what he does. I try to be broad and certainly many times I'll be first to highlight what's not my area of expertise and one that we should be looking at others. But where possible, I try to include some papers that give a broad outline of where we are. Excuse me. This is a fairly recent paper, actually 2014, that looks at prevalence and associated factors that go with Meniere's. And this paper really highlights the things that I see in practice, and it says this. Meniere's disease is commonly found in participants who are of older age, have a high BMI or body mass index, but they also have at least one disease from each of the groups that relate to allergies, immune dysfunction, and autoimmune, as well as poor mental health. Now, what's important, and as I say that, I'm probably, hopefully, it resonates with some and may unfortunately upset some others. A comorbidity or an associated factor is by no means indicative that it causes, or there's a causative link between one and the other. But what they're saying is when they look at a big database of people, in this case, 1,376 patients with Meniere's, and they did a list of what are common traits that these people have. And what they found statistically significant is that what is common with those that have Meniere's is these sorts of conditions. They suffer allergies, they suffer autoimmune conditions, they suffer autonomic dysregulation, and we'll go through what that means, or a combination of these things, including poor mental health. So if there's an association or a relationship, then look at this in a different light. Look at it as maybe as an opportunity to have these areas evaluated by someone qualified. Maybe consider adding some treatment, a lifestyle change, modalities, or whatever it might be to enhance your current care for Meniere's, at looking at, well, if they're associated with it, maybe I should be addressing these things as well. And that's sort of the main purpose of what I wanted to highlight in this slide. And again, hopefully you can see this, but again, you'll get a copy of my slides. Some of the physical and psychological triggers that are associated with Meniere's. And this is a great paper that looked at a patient's perspective. So it wasn't a really rigorous scientific explanation, but it was really based on a survey of patients that have Meniere's. What are the things that are known to be triggers or associated with them? So some of the physical things we know: diets, salt, certain meals, dairy, chocolate, caffeine, alcohol. Physical factors like tiredness, physical exertion, blood pressure, postural factors regarding head position, and we'll talk a little bit about this later when we talk about autonomic. Environmental, is there a time of the day? Is there in a windy weather, time of the year? Is there visual stimulus like watching TV, supermarkets, reading, looking at various things? Travel as a passenger is in car, flights, buses are also known to be some triggers. Crowded noises, crowded environments, loud volumes. Some psychological factors, stress, I think, is a common one that most people would agree. And some emotional triggers like weddings, Christmas, certain events can trigger things as well, and patterns of association and exposure as well. So this is a nice little paper that helps link some of the things that many of you experience to what others experience as well. And again, I bring this in there because if they are associated, then are you looking at these factors as part of your co-management? Are you seeking assistance or starting to use some of these therapies that can mitigate some of these responses or provoking factors as part of your care? So let's start with the metabolic. And here we're referring predominantly to systemic or global aspects that relate to predominantly your dietary components. So cardiovascular, blood pressure, cholesterol, these have been known to be associated with people with Meniere's. So again, is it worth getting your blood pressure and cholesterol checked and managing that? Is that helpful in managing Meniere's? There are some studies that would suggest so. Blood sugar, anemia levels, alcohol, levels of hormone, high BMI, most people would be familiar with salt, sensitivities to things like gluten, dairy, MSG, and tyramines, and in some ways have been linked or have been shown in some studies to be associated with being linked with triggers of Meniere's and other vestibular conditions. And these things here are maybe things that you can check yourself and investigate yourself. I would say as a primary care practitioner, I would encourage you to seek advice from those that are more trained in this area, whether it be your GP, whether it be your allied practitioner, whether it be a naturopath or otherwise. But I think there's good merit in being able to work with someone who can identify some of these triggers or provoking factors. When it comes to autoimmune inflammation, there are many papers that talk about Meniere's disease as an autoimmune condition. And there's some good substantiative evidence to say that that is the case. Now, like most things, it's never a one size fits all. For some, it might be another cause, but for a good number of people, autoimmune conditions seem to be associated with it. And they can include thyroid diseases like Hashimoto's, psoriatic arthritis, autoimmune arthritis like rheumatoid, ankylosing spondylitis, and SLE, which I think some of you would be familiar with. It has been linked to a number of viruses, from herpes to the chickenpox to cytomegalovirus and COVID. As a practitioner that sees many dizziness patients over the last couple of years, I can tell you we've seen many patients that have presented, whether it be through the vaccine or through exposure to the virus itself. There's a lot of papers that are now supporting COVID virus as a trigger for autoimmune conditions and its effect on vestibular disorders. When it comes to medication, we're looking at here what drugs affect our central processing. So I'm not necessarily talking about the drugs that you'll be familiar with that relates to managing Meniere's, but I'm looking at drugs that can greatly affect your central nervous system, and they include blood pressure medication, muscle relaxants, sleeping pills, diuretics in some instances, cholesterol lowering tablets, anti-inflammatory. And you're going to think, hold on, if cholesterol and inflammation can contribute to Meniere's or provoking Meniere's, but at the same time, cholesterol lowering drugs and anti-inflammatory medication can also be a trigger. This is where I would suggest, work with maybe an integrative medical practitioner or a naturopath or someone skilled at looking at maybe non-pharmaceutical means of regulating your cholesterol and regulating your autoimmune and inflammatory condition. Antidepressants also can be involved. And when we start talking about mixing drugs, and in most instances for many people, seldomly are we taking a single drug. It's normally one drug and another drug to combat something else, and then another drug to combat the symptoms or side effects of those two drugs. And we get this, what we call polypharmacy. And when you're taking more than 3 drugs at one time, your risk of falls and your risk of affecting that central nervous system is exponential. So this is where I probably would suggest working with your neurologist or your GP and say, look, I'm concerned about the combination of drugs that I'm taking. Can we evaluate them? Can we consider them, particularly in light of my instability and my dizziness and my Meniere? So it's a discussion that I would encourage you to have with your primary care practitioner, in particular your GP. When it comes to neuropsychological, this is a big area. And again, I just want to make the point clear here. I'm not necessarily stating that a psychological condition causes Meniere's or Meniere's can cause a psychological condition. Although we do see a strong relationship between them. Again, I'm sure many of you would agree there. But understand that if there's an issue here that relates to mood and depression and our emotions, then it's one that I would strongly encourage you to consult with a qualified psychologist or a counselor that has experience with working with people with chronic and persistent dizziness. Now, that's only a small subset of people, and I do have people that we work with that can assist them. Certainly reach out to me if you need a list of those names. But at the same time, working with a primary care practitioner that can do rehabilitation, they should also be endeavoring to manage some of the mild symptoms that relate to fear, anxiety, and depression. Now, not by any stretch of the imagination do I suggest that I would step in place of a counselor or a psychologist, but working with someone, giving them the confidence and giving them the understanding of what they can do and the targets and all the things that go around a supportive nature therapy. You'd be surprised at the sort of benefits that we see with patients that relate to their anxiety and panic and fear and their hypervigilance and their depression. So it can be a side effect or a benefit of neuro-rehabilitation. But it's, in some instances, you do need to have that external person involved. So as I said here, an association, a link doesn't necessarily mean causative. And I just want to make that point because too often we see people that present to our office and they're being ignored by their primary care practitioner, whether it be the neurologist, specialist, ENT, or otherwise. And because the condition, either they're not aware of what it is or how to manage it, they're often just given some antidepressants or anti-anxiety medication, and they're asked to, well, that will fix it. It is a real condition, what you're suffering. We should be acknowledging that, and we should be supporting you in many ways, particularly in the neuropsychological field. I'll read this. This is from this paper, and it talks about the influence of psychological factors in Meniere's disease. And it says here, a vicious circle of interaction seems to exist between the somatic organic symptoms, which is basically the dizziness, the vertigo, the instability. That's the somatic, or what you feel, experiences of Meniere's, and resultant psychological stress. The frightening attacks of vertigo seem likely to produce and increase the level of anxiety, thereby worsening the emotional state. And the resultant anxiety provokes various symptoms, probably through disorders of the autonomic nervous system, accompanied by the increased levels of stress-related hormones. And this is what I want to talk about. I want to work on, or help provoke a discussion and thoughts amongst yourselves about how you can get the brain to work better to manage what's going on in the ear. So when it comes to neuropsychological assessments, there are many levels. And I'll talk about the things that I do in our office. And again, my job is not necessarily to to replicate a psychologist, but sometimes to show as a screen to identify where some obstacles might be, but also as a yardstick that as time goes by, we can see objective measures of change. In our office, we use what we call a QEEG, or quantitative electroencephalogram, where patients would wear this funky looking shower cap with electrodes that are attached to the scalp, and it measures electrical activity. And we get these pictures that denote areas of hyper and hypo function. And with that, we can see the areas that probably need some support, or areas that need a bit more nurturing, or areas that need more stimulation. And we can gather that from this QEG. And from that, we can do neurofeedback therapy that can guide the patient through recovery. Other forms of therapy can be questionnaires like anxiety questionnaires, stress questionnaires, dizziness questionnaires, tinnitus questionnaires. All these questionnaires, which some of you may have been exposed to, give us a snapshot of where some of the mental health issues or states may be. Some of the treatment approaches should always encourage what we refer to as a team approach, where we look at a psych, counselor, or someone with experience in this area. And they will generally do a full evaluation. They may do cognitive behavior therapy. In our office, we do a lot of empowerment strategies and therapies. We do some mindfulness practice. We really try to encourage the patient to take ownership and empower themselves on what they're experiencing, learn strategies or hacks that they can adopt when things aren't working as good, and try to just give them the tools that they can work through this themselves. We're always here to support them, but trying to get a patient to learn strategies to manage this independently is one that we certainly encourage in our office. Other strategies can be by feedback therapies. We do heart rate variability, which is a very sensitive way to measure the body's ability to regulate stress. And we measure the heart rate as an outcome measure for that stress response. And that stress response might be an exposure to something. It might be a positional, so from a laying to a standing position. It might be deep breath. It might be a certain position. So we look at how the brain responds to stresses. And we have people come to us saying that they experience symptoms in certain positions. So sometimes we may do a modified exposure to it, try to identify, try to get some concept of awareness, and then put some context around stabilizing around that exposure, so we can neglect or negate people's experiences that they often have. And there's some good little take-home or home-based therapies. You can look at what they call heart math. There's some little training tools that are relatively inexpensive that you could use at home to train the brain to be more resilient to stresses. So I mentioned before about our autonomic system, and some of you again may be familiar with it. It's really it's that autonomic or automatic system in our body that we don't have to think about. So as I chew food, my mouth produces saliva, my gut produces enzymes to digest food. As the food goes down my mouth, it goes into my tummy, my stomach starts to digest the food, and as it passes through my abdominal cavity, you have this peristalsis or constriction of different parts of the gut, and that happens all automatically. You don't have to think about that, and that's just one example. So it controls our skin, our sweat receptors, our digestion, our breathing, our gut function, our stress response. These are all a product of our autonomic system. So when we have dysfunction in that area, we can get lightheaded, we can get bowel or bladder dysfunction, we can get sexual dysfunction, we can get sweating, skin and nail changes, and we can get intolerance to position. Some of these do need to be evaluated by a cardiologist, but more often than not, it's a brain or a central nervous system problem. and it's the brain's inability or inappropriate response to a stress that we're seeing. So when you touch someone on the shoulder, ordinarily that should be a fairly benign touch, and it's like you turn to the person and go, "Hi, how are you?" But if someone's hypervigilant and very startled easily, as you touch their shoulder, they get that startle response. The pupils dilate, the skin blotches, they start sweating, the gut, goes into a knot. And they can't think about what they did 5 minutes ago. Well, that's an inappropriate autonomic response. And that's what we refer to as a dysautonomia or poor autonomic dysfunction. And that's a really, really important thing, particularly when it comes to people with Meniere's. And something that we go over and over. And it's one that is often neglected because it's not an easy thing to assess. It's not an easy thing to manage. But it is one that really needs to be considered. And the ways in which we can assess it, we have these tilt tables which place position in different positions, and we're measuring their heart rate, their oxygen saturation, their blood pressure, their breathing rate, and we're assessing it in different positions, and we're evaluating, does gravity affect their stress response? And again, we can use various techniques that we have in our office, but you can use heart math at home using this visual interface, uses an eclipse to measure your heart rate variability, and you use breathing, mindfulness practice to help calm and sedate the body. And it's a great, great tool to adjunct to what we do and what you could do. So this is a recent paper that looked at the prevalence of sympathetic or autonomic dysfunction in patients with Meniere's. So people with cold sensitivities or cold extremities, because they have poor blood supply in their hand, happens in 97% of patients. People with shoulder and neck stiffness happen in 98% of people with Meniere's. Chilblains, we have IBS, which is irritable bowel syndrome, tension headaches, 69% of people, sweating in the hands, migraines, ear symptoms, palpitations, gastric disorders, stress-induced skin blotching, asthma, ulcerative colitis, which is a severe gut inflammatory disorder, and chemical sensitivities, which fortunately happens fairly rarely. But you can see a lot of these are well over 50%. So many people that have Meniere's have this autonomic dysregulation. And many of these, well, all of these symptoms are signs and symptoms of that dysregulation. So how do we treat it? What are ways in which we can use to regulate our autonomic system? And this is, we spend a lot of time in our office, and one that you should be equipping yourself with some home tools. You can use binaural sounds. So this is an app that you can download. Unfortunately, it's only on Apple. That you can play, and it has these frequencies of sounds that help calm and relax the body. Certain frequencies like alpha and beta waves that help relax the brain. And we measure that with our QEG. You can use these little biofeedback devices called Mentec, which measures your brainwave activity, and then through sounds helps regulate its function. You can use smells. Olfaction or smells are a great way to, again, calm and relax the body. We almost always recommend our patients use blue light filters. So either on their device or on their computer, or wear glasses that filter blue light. Smell, light, and sounds are three very, very powerful senses that our brain uses. And we can help calm that brain down by using the right frequencies of lights, frequencies of sound, and smells to help regulate it. Again, I'm sure many of you have used these and have found benefits. I'm not sure the reasons why, because really it helps filter and control some of these hypervigilant actions that our brain can go through. Other forms of treatment are a little bit more technical. We can use vibration. We have vibratory tools that we can apply on our neck We have the vagus nerve, and some of you may be familiar or heard of the vagus nerve. The vagus nerve is the opposite of our fight and flight system. The vagus nerve puts our body in our rest and digest state. It's the one that we really should be stimulating more. And any of the things that I showed you in the previous slides can help stimulate that vagus nerve. But some more direct therapies can be vibration, in particular on your carotid. We can use stimulators on your ear, little nerve stimulators to stimulate the vagus nerve. And in our office, we use certain laser lights, which can help stimulate the vagus nerve as it runs or courses along the carotid artery, as well as stimulating your gut where the vagus nerve also lives. So there's different ways in which we can be direct or indirect therapies for stimulating your rest and digest. Other things worth considering is your proprioceptive system, your neck, your shoulders, your jaw, conditions like chronic pain, migraines, insomnia, if you've suffered from a concussion or whiplash. These are all conditions that are known to alter, or for lack of a better word, scramble that brain. So what it takes in, the information that it takes in, is misrepresented. And so you can get things like chronic pain, insomnia, migraines are a product of that brain stem or brain not working as well as it should. So these conditions, if you also suffer from them, should also be managed, because it will have a beneficial impact on your Meniere's. Most of us have been exposed to vestibular therapy one way or another. Look, the jury's still out. There are some studies that show that it's a benefit. There are other studies that show that it's generally not particularly helpful. It's a personal thing. I've had people swear by it and say that it saved them, and others say that it hasn't. In my instance, I think the benefit from the therapy comes from the therapist. I think if you've got a strong relationship with your therapist and you're working with them and they're supporting you and guiding you, to me, that's where the benefit is, more than the exercise itself. Now, I say that as someone who's done a Ph.D. in vestibular rehab, but this is a great paper that was only recently published that looked at a systematic review, which is the highest review of research. And it looks at all the papers out there and it says, it works for some, doesn't work for some others. It may benefit, it may not benefit. So it's worth a shot, but probably don't raise your hopes up. But that is, if you go through the papers, they're really only looking at very standardized rehabilitation. It's not what I would define as a neuro-vestibular rehab, one that looks at the brain in conjunction with the ear. The standard therapies only are based on the inner ear and seldomly look at much else. Visual processing, some people, when they look at these pictures, they get, their heart raises a little bit, they start getting a little dizzy, they'll turn away from the screen. When we have these visual processing issues, these relate to how the brain is taking in visual input, and we see this quite commonly with Meniere's as well. There are tests that we can do. I won't spend much time on this, so I know we're pressed for time, called the subjective visual vertical. I encourage you to look at it. It's, again, when there's a skew of information from the inner ear, the brain doesn't compensate. And so the perception of where vertical line is gets skewed. And so we may walk around with our heads tilted, or at least our perception of the world being not vertical becomes apparent. And there's this test here, the bucket test, using a specific app that can help measure subjective visual vertical. Again, I'll pass through this pretty quick, but we can measure eye movements through different tests. Some of you have used these goggles that help record eye movements. We can do these tests that measure and record how you read, and we can get this picture of how accurate you are in reading, whether you jump words or whether you read word by word. this is a test that most of you have seen where you use these goggles. You might do this optokinetic test, and you've probably seen your eyes look amplified with this sort of picture. There are treatments that you can perform regarding eye movement therapy. And again, I know we're pressed for time. I won't spend much time on this, but there are therapies that you can do that involve following a target with a stationary or busy environment. And we would grade this along the scale from being quite easy to more challenging. For some people, following a moving object like a football, when the background is moving like it is here, can be quite a difficult challenge. And we would work with patients and ensuring that they have the capacity to do this. Virtual reality is another emerging area that has been shown to be quite helpful in placing people in a provoking environment. I know that may scare someone to say, well, I don't like a shopping center, or I don't like an elevator, or I don't like a busy environment, so I'm not going to spend any time there. It's not an approach that we would adopt, and not one that I would encourage patients. I would certainly hold their hand and, in a very supported environment, gradually do an exposure to these things to a way where they could conceptualize around it, they had strategies around it, and they felt comfortable around that environment. Again, we want people to live a healthy, fulfilling life and doing the activities that they enjoy. And unfortunately, as time goes by, exposure to these environments, being social with their friends, becomes compromised over the time, and we really don't want to see that. So training one's neck and proprioception is really important, particularly if you've had things like arthritis and whiplash injuries and migraines. Training how your neck and spine functions, whether it be through passive or active therapies, is one that, again, that I would encourage you to work with. You can work on people's jaws, you can work on people's balance, on their spine, and just on jaw. I know the crew's going to talk about this a bit later, but my next talk is all about how the jaw is an area that can be a source of irritation for Meniere's and chronic dizziness, but also can be an opportunity to help as well. Some of the more emerging techniques at the moment, particularly as it relates to tinnitus, not necessarily Meniere's as a condition, but controlling tinnitus. Transcranial direct current is one that's been very promising in the last 10 years in ways in which we can stimulate or dampen parts of the brain that relate to auditory processing, in particular tinnitus. And it's been shown repeatedly that this form of therapy can help reduce tinnitus perception and experience. Excuse me. Other forms of what we call neuromodulation is where we can use photobiomodulation. I know the big words. All it means is that we can use these funky looking lasers on different parts of the head as it relates to inner ear function or as it relates to tinnitus. So again, more recent data over the last 10 years has shown some promise to say that the use of these cold lasers or transcranial lasers can be used to help inner ear function and areas of the brain that relate to either anxiety or tinnitus direct. So yeah, this was I'll preface that this particular study, which is fairly recent, was in rats. So it hasn't been shown in humans yet, but I just wanted to show that because it was incredible. Laser treatment, which is these cold laser therapy, minimize the damage from the inner ear. So these rats had gentamicin injected into the inner ear, which, as you know, kills and destroys the hair cells in the inner ear. What the laser showed, it actually, I'll read it here. So histological study. So when they did a sample of the inner ear, reflected the functional results, showing an increase in hair cell density, and basically it started to repair the function and the anatomy of the hair cells that were previously destroyed. Now, again, I preface to say that this is in a rat. This is not something that I would necessarily say it's going to happen in human, but it's an exciting area that hopefully research will show that to be the case. So look, I want conclude on that, I know I've covered a lot, but I think I just wanted to highlight a few things to you. A healthy brain, a brain that is more resilient, more adaptable, is one that's going to treat you better with respect to your Meniere's. And it's one that you should be working with a team of people in whatever capacity, whether it be mental health, whether it be physical, whether it be nutritional, biomedical, whether it be autoimmune, whether it be a combination of all those, in ensuring that your brain is as robust as possible and can take whatever the Meniere's peripheral issue can throw at it, and it has the capacity to be to not affect you as much as what it probably is. So I just want to sort of impart that, and it's really the approach that we take at our clinic at Brain Hub, and it's one that we've had some good success over the years, and one that we're continually learning to enhance. And we're bringing on new technology, and it's also things that I teach other practitioners. So hopefully, practitioners that you may see, whether they're scattered throughout Australia or out throughout the world, hopefully there are practitioners that have maybe taken a course of mine over the years and can maybe impart some of that information to improving your care. So with that said, I just, if you want to reach out to me, I'm contactable with different means, and I'd love to answer any questions. I know the crew tonight are taking some questions from you and from those that watch the recording later, and I'm going to be working with Anne at a later stage and maybe answering some of those questions in different means. So I'll just finish with the last slide, which is one that I love to show. Love your brain. You only have one brain. Love it, because it will definitely treat you better with this and many other conditions that you may or may not have. So with that said, I'll pass it back on to the host.
Thank you. Thanks, Carlo. Yeah, really great presentation. So much information.
Yeah, it was wonderful.
Yeah, really. I think we need to watch it a couple of times to absorb it all, because it's so much, you've shared so much with us, and it's some very useful information.
Yeah.
I'm interested in the laser, actually. The laser with the to help with hair cells.
Yeah, I did a cursory check. I didn't look too deep, but I couldn't find anything on the surface that was showing human-based studies that can show regeneration, because that's a game changer. Because it's we're all taught that gentamicin both can be a cause of, but also be part of the therapeutic aspect for some. And when you damage those hair cells, it's taught that that's it. It's not much you can do about it, and you just live with it. But it may be that for early stages of Meniere's and other conditions, and if it's due to ototoxic conditions or otherwise, it may be helpful for that recovery. But jury's still out on that one.
And just one more thing. It's not a question. Just virtual reality, where you've got the whole headpiece on your eyes. I mean, that must be pretty weird for us people with Meniere's. I mean, can we lose our balance? Seriously?
Yeah, look, we often start seated, so we have a good grounding. We know where we're at, so it's all graded, and that's the key to it. It's not we don't fully immerse you and go, well, there you go, all the best. It's hold your hand through the process. The good thing about the software that we have, the virtual reality one, which is a practitioner product, is that we can change what you see and your exposure. So, for instance, if you're walking through a shopping center, we might change the speed of it so it's really slow. We might only put a few items on the shopping aisles. We won't have anyone passing past you, and you're slowly tiptoeing around and going, okay, I don't feel too bad about this. I'm okay with this. And as you get better at it, we start making it faster. We start putting more things on the shelves. We start having people come at you with trolleys, and so your exposure increases. But it's done in a very graded, progressive way that you're supported. I can't stress that enough. And that's why I think what we do works, is because we acknowledge where someone is at, and we we hold their hand through that process. And there's always dips and there's peaks and troughs. We get that and we set that expectation, but it's really a matter of just working through it and just, celebrating those little wins. And when we do, it's like, but you might come to us saying, I just want to go, I want to fly a plane, or I want to get in a car, or I want to go in a lift because my son, I want to get to the top of the building because I want to see the views of Sydney. And that's been one of my goals. Well, we work with patients to try to achieve each of those goals. But that comes from an interaction and goal sharing. And we have health coaches in our office that help work with patients and setting those goals and overcoming some of those barriers as well. So there's different elements that work. But I guess working with the right pit crew is really important. And I'm not saying that we have all the answers, but try to look at those different options. And if someone looks at it with with only a one tool approach, in my opinion, it's probably not going to help a great deal. It may help the peripheral aspect, but it's not going to help that central component that I mentioned.
Okay, thanks, Carlo. Okay, I think we should call it a night now. Okay, and thank you. Really appreciate your time coming. Thank you. Really, we do appreciate it. And looking forward to TMJ.